Eyelid infectious states as well as the neoplastic states can sometimes be encountered as if you're working as a general physician or even an ophthalmologist usually encounter these conditions which are relating to the infectious states of this particular eyelids and the structures that are involved in the eyelid functioning. So it can be the glands, that can be the sebaceous glands that are involved in the neoplasms as well as in the infectious states. And on the other hand, we have the muscular structures, we have the skin, we have the fascia. So all of these structures are basically they are involved and they are prone to the development of the infectious states and the neoplasms. Over here in this particular lecture, we'll be summarizing these conditions. Working as a GP, a general physician, or an ophthalmologist, you should know how to diagnose and how to examine, how to take history from these patients, because it's sometimes very important to get to know these patients in detail. So knowing the history, knowing the history background towards a particular patient is very important. The personal traits are again very important. The patient particulars are again very important, which are again start off from the age, the sex of the individual. Then you should be noting down the occupation that he's been involved into, because that is going to highlight the conditions, the environmental conditions of that patient that make him more prone to the contagious infections in his environment. So again, all of these patient particulars are noted down in detail when you have a patient and you have a suspicion that this particular patient is suffering from some sort of an eyelid infection, or either this mass that I'm looking at is a neoplasm. Again, you have to distinguish between a benign and a malignant neoplasm over here, but right now focusing on the eyelid infections particularly, which would give you all the inflammatory signs when you're looking at the patient. The patient would have the redness, the rubor, the calor that would be present locally in the eyelid region, as you can see over here. In this particular picture, you can diagnose that this patient is suffering from some sort of an eyelid infection. May it be a viral infection, may it be a fungal infection, for example, mucormycosis. So it's one of the kinds of the fungal infections that the patient can be suffering from. It can be blepharitis, which is again bacterial in origin. So these can be some sort of infections that the patient can be suffering from. But by just looking at it, you can at least diagnose over here that this is an infectious state, or this is an inflammatory kind of a condition that the patient is suffering from. The secretory glands, if they're involved, that would suggest the pus secretions from the glands, as well as you can see the crusting. That is the main highlight of the bacterial infections over here. So again, there is an inflammation, there is a localized inflammation over here, and all of these are basically the signs that are indicative of the inflammatory changes that are occurring in this particular patient. What can be the differential diagnosis towards this eyelid infection is again very interesting. It can be a stye. In this particular case, it's most probably a stye. It can be a superadded infection along with the stye. So it can be one of the acute infections, which is known as the stye. On the other hand, the patient may have a chalazion. Chalazion is basically the same condition as in the stye, but it is a chronic phase of the infection that we would be considering as, or we'd be terming as, the chalazion in this regard. Whenever we are talking about this stye and chalazion, you have to remember that these are the inflammatory changes of the sebaceous glands that are present at the eyelids. Now, there are two groups of glands that are present over here, mainly the meibomian glands, and then we have the glands of Zeiss that are present over here at the eyelid margins, and that are responsible for the formation of this acute and this chronic stages of the infections over here. Then mainly we have the preseptal cellulitis, that is basically including the whole fascia, and it is basically the whole precellular fascia that is present over here. It is involved in this particular infectious state. And then we have the ocular herpes. The origin is, as the name indicates, it's viral in origin over here when we're talking about it. And then we have the orbital cellulitis. As you can see, it can be a preseptal cellulitis, a condition like this, and then we have the orbital cellulitis, in which the structures of the orbit are also involved along. The infectious state has prolonged, and the orbital structures are also involved in this inflammatory kind of a condition. Then we have blepharitis, that is mainly the lid margins are affected over here on a whole. It can be the upper eyelid as well as it can be the lower eyelid that is involved. The clinical features, the treatment guidelines will be discussed subsequently in this lecture. And then we have the viral conjunctivitis, that is again viral in origin. It's quite contagious. It has its particular clinical features. So these are the range of the differential diagnosis that we have to choose from whenever we are suspecting any kind of an eyelid infection. So it's a wide range of infectious diseases. The origins are different, ranging from the viral, bacterial, then we have the fungal origin of the infections in this particular state. Still, we have to identify this condition because the treatment guidelines would be dependent upon the final diagnosis of an ophthalmologist. Then moving on to Stye. In other words, it's also known as hordeolum. So it's another word, it's another clinical terminology that we usually give. Now, what are the different kinds of the styes, or what are the different, it can be involving the upper eyelid as shown over here, and it can be involving the lower eyelid as well in a lot of patients. We have different clinical features that are relating to the stye. There are this nodular appearance that is reddish in its appearance. It's again nodular. It's involving the lid margins. All of these clinical features are present and they are indicative of a stye. The duration of the stye is again very important because that is how we're going to differentiate whether it is a stye or either it is a chalazion over here. So differentiating is just done upon the duration of the disease. This is how basically we differentiate between a stye and a chalazion. Knowing the clinical features, once you have diagnosed the case with that the case is suffering from a stye or it is a case of a hordeolum, you should know how to treat these cases. The treatment is usually incision and drainage that is given over here. As you can see, the approach is usually retro lid. So it's basically posteriorly than the lid rather than an interior approach towards that, towards the opening or towards giving an incision to open up the stye and drain the particular localized area over here. So you can see, first of all, you give that minute incision. You evert the eyelid, you give that minute incision, and then you finally drain it and you cut it open, you drain that particular incision. Obviously, you will be giving the prophylactic antibiotics along with it. So just to give up the cover towards the infectious state further on and to dry up that area from that infectious state and to get a complete recovery in this particular patient. This is how you go about and start draining that particular area of incision. The complete incision and the complete anesthetization is very important over here because first of all, to get that aseptic conditions out there is again very important. You have to completely drain that area that is suffering from the recurrent stye formation. One should keep in mind that this treatment, which involves the incision and drainage, is not done on a regular basis. Usually, you give an antibiotic cover to the patient, and usually, you ask the patient to have the hot compresses that would be quite relieving for the stye. If it's just an infection of a gland or two, that can be treated by just giving an antibiotic cover, giving the topical antibiotics that are coupled up with the hot compresses therapy over here. So this is usually the treatment of choice in a condition of stye. But if it is a recurrent condition, that is again very painful in a lot of states. So you should know how to deal with these conditions, and you can perform these minor surgeries to treat these conditions. On the other hand, we have a chronic state which is known as chalazion. So whenever you have a stye, again, it's the infection of the meibomian glands and the glands of the Zeus, but it's of a chronic duration out here. So the chronicity is the main factor over here that is differentiating between the stye on one hand and the chalazion on one hand. The clinical features would be quite similar, that the nodular appearance, the reddish appearance, the pain, the fever, that is going to be subjacent to both of these conditions. Hot compresses are usually advised to the patient, but they do not prove to be quite helpful for the patient. So usually you have to perform the incision and the drainage, that is the IND surgeries even in these patients. So this is the whole treatment guidelines that are given out for these patients of stye or chalazion over here. Again, you clamp that area, you perform that incision and the drainage, and these minor surgeries are performed along with that. This is a particular spoon that is used for the chalazion surgeries, for the drainage and for removing the clump of pus that is present over there. This is known as the chalazion spoon and the chalazion clamp over here. So the removal of the debris from the chalazion is performed in such a way. The incision is given to cut open the side, and then you clamp that area, you scoop it out, and you just perform the reconstructive surgery on that chalazion. So this is the whole surgical procedure that is performed for the chalazions and styes as well. Then we have a condition which is known as preseptal cellulitis. Again, as the name indicates, the septas, and if you remember or if you recall the anatomical structures that are present in the eye and how there are these septas are basically present where we have the tendons of the levator palpebrae superioris. So this is a muscle which is giving off its tendons, and that is again superimposed by these septas. So usually the infections are contained towards the eyelid, and they do not involve the orbital structures whenever we have the preseptal cellulitis over here. But we have to keep in our mind that we have the exogenous infections as well as the endogenous infections whenever we are talking about the orbital cellulitis. Whenever we are talking that it can be homogeneous condition, it can be a hematogenous spread. Hematogenous spread basically means the spread through the blood, and either it can be the infectious states that travel from the neighboring structures. Now, what are the neighboring structures whenever we talk about these preseptal cellulitis condition? The different fossas that are involved over here, and that can communicate with these orbital structures. It can be the infratemporal fossa. Then we have the different sinuses, for example the maxillary sinus, the frontal sinuses. Infections from these sinuses can even travel to these orbital structures. So we have to keep in mind the origin of these infectious states. Treatment guidelines would obviously include the treatment with the antibiotics. The steroidal treatments are usually given for these patients. Then even we can have the sources from the outside, from the environment. Usually the patient would give you a history of a waxing of this eyebrow area, and usually after that the patients present with this preseptal cellulitis condition. It usually doesn't occur in all of the population, but the population that is more prone to the development of this preseptal cellulitis would be in whom we are considering that they are immunocompromised, and the immune system is not working in a proper way. So only then they will encounter these infectious states which are known as the preseptal cellulitis over here. Orbital cellulitis, as I was talking about, we have the different kinds of sources. It can involve the exogenous, it can involve the endogenous sources. So knowing the source of infection is again very important over here. It can be even a fungal source of infection. Whenever it is a fungal kind of infection, we are going to term it as mucormyosis. If it is a bacterial kind of an infection, the organisms that are usually involved are the MRSAs, that is the methicillin-resistant Staphylococcus aureus. So this is the usual organism that is responsible for this orbital cellulitis. And then on the other hand, we have Haemophilus influenzae that can again result in such kind of an orbital cellulitis kind of conditions. We usually come across a lot of children who are suffering from these orbital cellulitis or orbital infections, and they give you a history that they have been recently vaccinated for Haemophilus influenzae. So these are the points that you should remember whenever you are taking the history from the patient of orbital cellulitis. On the other hand, we have ocular herpes. So herpes, as the name indicates, it's going to be a viral infection. The organism usually involved is the herpes zoster over here. The condition is herpes zoster ophthalmicus in all of these conditions. The picture over here, as you can see, we have these secretory nodular structures that are present involving the skin of the lower eyelid, or either it can be the skin of the upper eyelid. So you have to remember that these can be the different infectious organisms that are resulting in different sorts of infections. Again, we have to rely upon a lot of investigations that are carried out in these patients who are suffering from the ocular herpes. On the other hand, we have blepharitis. Blepharitis is a very common condition involving the lid margins, and that is the main source of infection in this kind of a condition. The mainstay of diagnosis would be the crusting that the patient would give you a history of. Blepharitis can be usually of a bacterial origin, and the treatment would also relate with the topical antibiotics. Of course, it can be the topical antibiotic ointments, as well as the drops can be advised or coupled upon with the ointment therapy. So knowing this condition, diagnosing this condition is usually done upon the slit lamp examination. When you examine these patients, the patient would give you a history of sticky eyes upon waking up, unable to open his eyes due to stickiness. The crust formation is quite thick in these patients. So these are the particular clinical signs and symptoms that are related to this condition, which is particularly known as blepharitis condition. The eyelids are swollen and reddened. This diagram is basically briefing down these symptomatologies that are relating to it. The scaly scabs, the crusting is very important, and that is very pathognomonic. We have the bacterial infection. Usually it is of bacterial origin, although it can be viral as well, but usually the most common occurrence is through the bacterial origin over here. Then we have the viral conjunctivitis. When we talk about this, it can be a very infectious state. It can be a very contagious state when we talk about this viral conjunctivitis. The patient should be asked to he should be aware of the fact, and basically the physician has to educate the patient that this is a contagious disease. The towels are to be separated, and so that the infection doesn't spread to the people around the house. So this is the main education that has to be given to the patient, as well as the people who are the primary caregivers or who are surrounding the patient in the same environment. So this is a condition in which, again, we would have those secretions. There would be the redness of the conjunctiva that is clearly shown over here. The treatment would encompass the antivirals. The topical antivirals would be given in these conditions. It's usually a self-limiting condition. So you just have to look for and foresee if there are any complications that are related to these viral conjunctivitis states or not. So these were the whole eyelid infections that we talked about. On the other hand, one should know that whenever you have these infectious states, there is a thin borderline between these, between the diagnosis of these infectious states, which are again nodular in their nature, and how to distinguish them from any benign tumors and the malignant tumors. We have in the differential diagnosis, we should include the idiopathic nature infectious states, as well as we should include the non-infectious inflammatory conditions of the eye. That would include the polyangiitis, the granulomatous conditions, the IgG4 conditions that are sometimes associated to be with the non-infectious kinds of the orbital inflammations that are sometimes presented to you in the OPD, and you should know how to diagnose them. So once you have investigated the patient in detail and you know that he's not suffering from all of the above conditions, so it's going to be a none and above condition that you should apply, and then only you should label the patient should be suffering from an idiopathic inflammatory condition, or either, on the other hand, it can be a non-infectious inflammatory condition as well. Now, once you have these nodular structures, you should know that these nodules, these patches, can be sometimes the benign tumors as well. The benign tumors can be the xanthelasmas, it can be the dermoid cysts. On the other hand, we have the seborrheic keratosis that the patient can be suffering from, and we can have papillomas as well. So just by looking at these conditions, you're not able to differentially diagnose these conditions. But it's just that these are the nodular patches that are present on the eyelids. If it's a xanthelasma, the causative factors are quite different in this case. It can be an irritative purpose out there. Sometimes the sunlight exposure, sometimes the familial predisposition is making the person more prone to the development of this xanthelasma condition over here. Then we have a dermoid cyst. Dermoid cysts are usually benign in nature, so you should know how to take the biopsies and just to rule out any malignancies in these cysts. Seborrheic keratosis are again the benign conditions, and then we have the papillomas, which are again benign in nature. Even though we know that these conditions are benign, but they are mostly surgically treated. This is done just to cater the visual impairment problems of the patient and the physical disturbances that they are causing to the patient. So this is the usual course of treatment that is given to these patients. Then we have the benign eyelid tumors. That can be the periocular capillary hemangiomas as well. Then we have the cornu cutaneums, and then we have the nevus in the lower eyelids, as well as the cavernous hemangiomas. First of all, dealing with the periocular capillary hemangiomas, just look at the condition. It's basically a hemangiatic condition. It's a collection of the blood vessels. Again, there is an abnormal growth of an abnormal tissue out there. So this is a hemangioma that is present. One should be aware of the fact that these hemangiomas, they can be present on the eyelids as well as they can be present preorbitally. So whenever they are present preorbitally, they have their pressures that are created on the preorbital structures, as well as even the nerves can be compressed in a lot of cases. Whenever the nerves are compressed, obviously the vision is impaired in all of these individuals. So these are some of the complications that can occur depending upon the site of these capillary hemangiomas. So sometimes you have to surgically treat these hemangiomas and take out the mass of the abnormal tissue in this case. Over here you can see there is a Cornu Cutaneum. So it is basically a horn that is basically present over here. It is resembling a horn of an animal. Usually it is a benign condition, but sometimes it is a borderline malignant condition, or even it can encompass into a malignant condition. It is made up of keratin, so you should know it is the same material that our nails are made up of. So you usually can chip it off without even giving a local anesthetic. But sometimes if it is involving the basilar structures, it is involving the skin, it is involving the fascia as well, you have to give the local anesthetic and you have to freshen up the ends and perform the reconstructive surgeries in these particular cases. Over here, you can see we have the nevus in the lower eyelids. So whenever we have this nevus in the lower eyelids, it's basically a range of benign eyelid tumors again over here. And again, it is a thin borderline. We have to keep checking on whether it is a benign or whether it is a malignant state that the nevus has gone into. Then we have the cavernous hemangiomas over here. Again, the cavernous hemangiomas are again a collection of the blood vessels and the blood. It is a darkened pool of the blood. Usually the appearance is reddish or bluish in their color formation. Talking about the xanthelasmas, the causative factors are again the familial predisposition, as we've already talked about. There is a genetic predisposition towards the development of this xanthelasma structures. These are also known as the skin tags, the collection of fats that are present over here. The sources that are proven to be irritative for the skin lesions over here. It can be the exposure to the sunlight, it can be trauma, it can be even the infectious states of the chronic kind that can lead to the development of these xanthelasmas. But whenever you have a patient of xanthelasma at your hand, you should perform the blood cholesterol levels on these patients just to rule out any high cholesterol levels that are leading to these fat depositions in the skin. So this is the investigation of choice over here. Whenever you have a patient of xanthelasmas, the treatment of choice to rule out or to cut out these xanthelasmas is usually a surgical treatment that is performed for this kind of a condition that we usually encounter in this particular state. There's a surgical treatment that is performed, and it can be even the lasers, it can be the cauteries that can be performed in these patients of xanthelasmas. On the other hand, we have the dermoid cysts. So the dermoid cysts are usually again a benign group of diseases that we're talking about. It's usually a collection of the blood vessels that are present over here. It is benign in nature. It is a growth of the abnormal tissue that is allowed at the eyelids. Again, it can cause the mechanical problems depending upon the size of the dermoid cyst, and again depending upon the location of this dermoid cyst. Either it is on the upper lid or either it is on the lower lid. So this has to be evaluated in these particular patients. Then we have the seborrheic keratosis that is usually seen in these patients. So knowing the seborrheic keratosis, it is usually the traumatic conditions that are leading towards the formation of this keratotic kind of a condition. Again, it's a benign condition, but it can cause, it's a senile or an age-related or in advanced ages usually come across this seborrheic kind of conditions. So the treatment of choice again over here is a surgical incision that is given, obviously. It is an unsightly site, and you have to treat and you have to give a cosmetic review to the patients as well. So you usually give out the incision and take out the keratitis that is present over there. Papillomas are again the one of the kinds of the benign eyelid tumors that we usually come across. It's usually that the glands are involved in this kind of tumors, and either it can be a meibomian gland or either it can be the glands of Zeus that are involved over here. Usually they are very small in structures, they do not have mechanical problems, but still if the patient is complaining and he has come up to you, you'd give him the antibiotic cover and perform the incision and drainage surgeries in these particular patients as well. Then we have the Cornu Cutaneum, or it's also known as a cutaneous horn. So it looks like this. This is basically a very superficial kind of a condition. The structure is usually made up of keratin over here. As you can see, it resembles an animal horn over here. So the structure is made up of keratin, and you can easily incise it without any pain. The causative factors, there are many causative factors. The main feature over here that you have to remember is the human papilloma virus that is mostly involved for the development of this Cornu Cutaneum in a lot of cases. So usually that is the diagnostic feature for the development of the cutaneous horn. Then basically we have other range of factors. It can be one of the factors is trauma. Then we have the patient may give you a history of burns. So again, the history taking is very important. Whenever you have this patient of Cornu Cutaneum, you should take the history in detail. If the patient has been suffering from any sorts of infections, if he or she has recently suffered from burns, it can be the chemical burns as well. So this would give you the irritative factors that made this development of this cutaneous horn. So basically, it's a non-malignant condition. Usually it is a non-malignant condition, but it's a borderline condition. It can basically encompass towards the malignancies over here. So on the other hand, we have the cavernous hemangioma. So even by looking at this particular child, you should diagnose it that he or she is suffering from this cavernous kind of a condition, or the cavernous hemangioma is the diagnosis over here. The usual appearance is this reddish bluish appearance that the patient would be giving. The mass would be sometimes, it is going to be varied in the size. The location is sometimes also going to be varied, but the colorish discoloration, the discoloration that it would be giving is usually the bluish purplish discoloration that is given due to the collection of the blood vessels and even the abnormal cells that are collected at the site. So then we have the periocular capillary hemangiomas along with it. So dealing with these both kinds of hemangiomas, that is the collection of the blood vessels, or these are the benign tumors that is relating to the vascular walls. So this is the mainstay, or this is the pathogenesis that is underlying these hemangioma. Either it is a capillary hemangioma or either it is a periocular capillary hemangioma that we're dealing with. One should know that it is usually a benign condition that the child or even the adult is suffering from, and usually the radiation therapies are coupled upon along with the chemotherapies to treat these patients. The surgical excisions, if they are causing any sorts of mechanical issues only, we perform these surgeries to get or to excise those tumors out of those particular areas. On the other hand, we have a lot of nevi. It can be even a lower eyelid, or either it can be an upper eyelid that is involved in this nevus condition that we're talking about. Usually this nevus is a benign condition that is occurring. So how do you identify this nevus that is presenting in the lower eyelid? It's the pigmentation that is occurring, it is the pigmentation that is bordering this particular area. A particular nodule is present and the pigmentation is encompassing those particular areas. So this is the condition that is occurring. This is known as a nevus condition that is occurring in the lower eyelid. Usually it is a benign condition. No surgical treatments are needed for this particular kind of a condition. You just have to note down the size. If there is any alteration in the size or the color of the nevus, that are the signs of malignancy. So you should know how to look upon or how to inspect these nevi that are present in the lower eyelid. If we are suspecting that it is some sort of a borderline nevus that is present and we are just looking at a nevus which can be malignant as well, we perform surgeries in these cases. We obviously cut open the site where the nevus is present, and then you approximate the two edges, you freshen up the two edges, you cut out the nevus and send it for the biopsy, send it for further investigations, and then you basically reconstruct the area which was involved in the nevi formation. Once you have gone through the benign variety of the orbital tumors that are present, we'd be now discussing the malignant eyelid tumors over here. So whenever you have these patients who are suffering from these nodular structures and you don't know how to classify these orbital tumors, you should keep in mind that the major classification is when you just look at the patient, you should know what can be the commonest tumors that are occurring in those age group. You usually classify them in children and in adults on the other hand. In children, they usually suffer from lymphomas in a lot of cases. Then they have rhabdomyosarcomas on the other hand. And as well as children who are suffering from leukemias, they usually suffer from the metastatic tumors of the orbital structures as well. So these are the commonest structures that you should keep in, the commonest tumors that you should keep in mind whenever you have the age group of children at your hand and they're suffering from these nodular tumors. On the other hand, we have the adult age group. Now, whenever you have an adult age group kind of a person who you can regard as in a senile age group or in an advancing age group, the tumors are localized depending upon the location of the tumors. That is basically mostly the lacrimal gland can be involved in the malignant tumors. We have two major varieties for the lacrimal gland tumors. Either it can be the epithelial tumors, and then we have the more aggressive non-epithelial tumors at our hand. Then on the other hand, we have a metastatic variety of tumors as well, which is basically the tumors that are metastasizing from the lungs as well as the chest, and the prostatic tumors, they usually metastasize to the orbital structures. So these are the particular points that you have to remember when you are making a diagnosis, and you have the patient particulars, you have the complete history of the patient. This is how you go about and investigate this patient of suspected orbital tumor in detail or in a sequential manner. The malignant tumors that you have to keep in mind whenever you have this patient of a nodule that is present on the eyelids or that is present on the orbital structures. First and foremostly, we have the most commonly occurring malignancy, that is basically the nodular basal cell carcinoma over here. On the other hand, we have sebaceous carcinomas at our hand. Then we have the squamous cell carcinomas, which are again quite aggressive in nature. We have the Kaposi's sarcomas. They're again the growth of an abnormal tissue. We have melanomas, and we have the Merkel cells carcinoma. So these are basically the range of the malignant tumors that are usually occurring in a patient, and you should know how to diagnose these cases. These are the particular pictures that are associated with these clinical malignant eyelid tumors. Talking about the nodular basal cell carcinoma. So as you know, the histology would indicate the basal nature for the cellular carcinoma, and the nodules would be the primary feature that is present in these patients. The therapy would include the surgical excision, it would also include the radiation, and it would also include the chemotherapy that is usually coupled up along with this rhomboid excision of the tumor that is done in a lot of cases. So usually where the tumor is present, you have to localize the tumor and you have to surgically excise this tumor, and then you perform the reconstructive surgeries after that or thereafter the tumor has been removed. Moving on to the squamous cell carcinomas, it's a more aggressive kind of a skin infection, or a more aggressive kind of a skin malignancy that is occurring in this particular case. So this is a typical picture of squamous cell carcinoma. Obviously, it would be finalized once you have the histological biopsies that are sent for the further investigations. You are going to furthermore diagnose whether the patient is suffering from the basal cell carcinoma, or either he's suffering from the squamous cell carcinoma on the other hand. Another variety for the malignancies is the sebaceous carcinomas, that is involving particularly the glands, that is the meibomian glands, the glands of Zeus that are present and that can be encompassing these tumorous stages over here. Then on the other hand, we have Kaposi sarcoma. So as you can see, these are the collection of the abnormal tissues that are present over here. The appearance is, you have to look at this particular reddish bluish appearance that is quite notorious for this Kaposi sarcoma. The prognosis is not quite good in these cases of Kaposi sarcoma. It's usually a metastatic kind of a condition, and so usually the patient, the surgical excision is performed in these cases, but you have to have a closer follow-up for these patients of Kaposi sarcoma. Then we have melanomas on the other hand. And whenever we look at these melanomas, as you can see over here, it's basically the collection of this pigmentation that is present in this condition, and it is a malignant condition. So diagnosing this condition by looking at this clinical picture is very important. You take out the biopsies, and these are not normal nevi that are present that we regarded as being benign or as the borderline category. These are the true malignant structures out there. Then on the other hand, we have the Merkel cell carcinomas. So whenever we look at these Merkel cell carcinomas, they have a lot of the mechanical effects. They're usually these big nodules that are present, the reddish bluish structures that are usually present, and they are also known as the neuroendocrinal carcinomas as well. So it's another name that is given to these Merkel cell carcinomas. So the treatment obviously would encompass the surgical excision of this Merkel cell carcinoma, and you obviously couple it up with the chemotherapies as well as the radiotherapies, and you perform a close follow-up for these patients who have been diagnosed with the Merkel cell carcinomas. So over here in this lecture, we summarize the different infectious eyelid conditions as well as the neoplastic conditions that can arise at the eyelid margins. We have a range of lectures that are present encompassing the different ophthalmopathies, or even the neuroophthalmopathies or the traumatic views of the ocular structures. So do watch the lectures on our website, sqadia.com. Thanks for watching, and get access to watch the complete lectures.